No, yeah, not yet. Now we're on. Yes. We're here. Yeah, there we go. Welcome. Welcome, everyone. Welcome. So if you're with us tonight, please put your name on the chat window. Let us know where you're coming from, what's your professional background. Some of you may have been with us since the beginning. Today is the last day. We're very excited to host you once more. I think it's going to be a great last day.
We'll be missing this.
Yes, absolutely. We should organize another one next week.
Yeah.
Yes, absolutely.
We wish you a very good Thanksgiving. And
Yes, for those
yeah,
in the US, it's Thanksgiving, we've been told. So happy Thanksgiving, everyone.
yeah.
Yeah. All right. So maybe we'll start. And so welcome. This is the fourth day of this 4-day challenge in lifestyle oncology. We are discussing everything related with lifestyle in the oncology fields. My name is Diana Ferreira. I am a certified lifestyle medicine physician, and I also hold a master's and a PhD in palliative care. And I work with ESLO, the European School of Lifestyle Oncology, and we're a lecturer, and I also provide some medical consultations. So I'm joined by Anabela once more. And hi, how are you today?
Hello everyone. So I'm okay. I'm enjoying this. So I'm an oncology nurse. I am specialized in rehabilitation. I also have a master's degree in this field, which is my passion. And I'm now pursuing a PhD in nursing sciences. So I work at European School of Lifestyle Oncology and I'm Cancer Center also. And I'm a board member of a Association of Research and Supportive Care in Oncology, which is the Portuguese affiliated of MASC. MASC, that is our sponsor in
Of
our
course.
course. Yeah.
Yeah, absolutely. So we're very proud of that. All right. So today I think I'm going to share my presentation again. And we always need a bit of time to get organized, even if we have three screens. All right. All right. So here we go. Let's start our last day. And today's theme is empowering change, how healthcare professionals can lead the shift in cancer treatment. So this is day 4, and we're going to be starting to speak about leading change and how professionals really have a huge role in leading this change in a lifestyle oncology. And why is that? Well, we as health professionals are a credible sources of information. Of course, this has been changing quite a bit over the last years, I would say, but we're still credible sources of information. And we have repeated opportunities to interact with patients. So we see them regularly, and that's an advantage. So we also know that nowadays people want information about health behaviors. So it's quite frequent that people ask about nutrition or physical exercise or even stress management. So it's quite important that we're updated as well. Counseling is effective. I don't think we believe in counseling enough, but as you will see, it's actually effective even in small doses. See, there's a few barriers to leading change, and one is the type of lifestyle health professionals have. So we are prone to high levels of anxiety and burnout. We usually have low levels of physical activity, few hours of sleep, and we eat very irregularly. So these are all barriers because we're not walking the talk, basically. So why is it important for healthcare professionals to adopt healthy lifestyles? Well, mainly because health professionals with good habits will influence good habits in patients. And we know that from different studies. So from a meta-analysis of 24 studies, we know there is a high correlation between regular physical activity in health professionals and advice on physical activity. So we know this is a requirement. And also doctors who do not smoke are more likely to advise patients not to smoke, which sort of makes sense. Sometimes we're not as comfortable providing advice if we're not doing what we're talking about. Then we know that doctors are more likely to register and initiate conversations about overweight and obesity if they perceive that the person's weight is greater than theirs. So this is a comparison mechanism, but it's actually really interesting that it happens. And then also, it's not neglectable that we're at a high risk of burnout. So we really need to take care of our lifestyle, of having good habits, also to be a bit more resistant. And we would also like to talk about the role of each individual group of health professionals, because each one is uniquely positioned to actually provide some advice in lifestyle oncology or intervene in this area. So for nurses, for example, several opportunities. So they have repeated and frequent contact with patients. And sometimes, for example, for oncology nurses, they spend so much time in the same room as the patient because they're providing chemotherapy. And even though they're not sitting all the time by the patient, there's repeated interaction. So that's particularly important. And then they have a close relationship with the patients. They're there for the difficult times as well in many cases. And we find as well, and this can be cultural, but patients sometimes get a bit more inhibited with doctors, maybe because of the hierarchy. We're not exactly sure, but with nurses, they spend more time, they tend to open up more and to actually ask more questions. So here, when there's more conversation and more opportunities for contact, it's also easier to identify barriers to behavior change. And then the advantages of having deeper knowledge in lifestyle oncology, it's an opportunity to keep up to date with the latest evidence, but also to get new tools to help patients, to be confident to answer questions asked by patients. And I'll give you an example. When I had lymphoma myself, and I remember asking the nurse if I could drink alcohol, and she said, yes, no problem, but no to vitamin D, which was hilarious at that stage. But this happens with many people, and this is because we're not trained as health professionals in answering these questions. So it's really important that we actually get some training. And then combining nursing with lifestyle mentoring, that's an increasing practice as well, and very needed because, again, patients really turn to nurses for advice. And then being confident and knowing when to refer. For example, if you are a nurse and you have a patient that you can clearly see has a low muscle mass, it's a great opportunity to refer to an exercise physiologist, for example, for intervention. We know that increasing muscle mass is really important to withstand therapy, to be able to have a less incidence of side effects, for example, so we can really act all together. Then pharmacists, different opportunities, but for example, access to patients in the community, and then repeated contacts and trusting relationship. And some people had the same pharmacist for years. So it's really a true relationship of trust. And why getting deeper knowledge in this area for pharmacists? And it's really knowing more about lifestyle strategies that can help in addition to pharmacological approaches. And for example, if people have, for example, neuropathy, and they ask for specific advice in this area, they can refer, for example, for acupuncture, or they can introduce the question or the issue of physical activity as well, and liaise with other professionals. And then just confidence to answer questions asked by the patients. And on the top of my mind, I can think about supplementation, which is a big one. And usually people are really interested in what can I do, what supplements can I take. And it's interesting it's really important to know what advice to provide, but also be aware that many supplements can interfere with chemotherapy, and it's really useful to have some knowledge in this area. Then exercise physiologists, so many opportunities for this group as well. So they have access to patients in the community, as pharmacists do. But also they have a very informal type of contact. They spend 1 hour with the patient or with the person in each contact, and again, it's a regular contact. And also they're the image of health, the picture of health sometimes, so that also provides some confidence to people. And then advantages of getting deeper knowledge in this field. Knowing basically the main physical limitations of cancer patients and what they can do, what it's not advisable to do, knowledge as well about oncology treatments, knowledge of adverse effects caused by treatments and effective interventions. And we were talking, for example, with the premium group about this, and fatigue is a big one. So fatigue usually leads people to not to exercise. And for if exercise physiologists just have this awareness that fatigue also improves with exercise, and what type of exercise to implement is actually a big help. They can provide advice on the remaining lifestyle pillars. For example, if they have basic nutrition knowledge, that's usually very helpful, because combined interventions of nutrition and physical activity are actually more effective. And they also can gain confidence to refer to other health professionals, nutritionists being one of them. Physiotherapists is really similar to exercise physiologists in terms of opportunities as well, because there's a lot of time of informal contact in the community, which is a very comfortable place for patients. And then some advantages of getting deeper knowledge, just again, having the knowledge and trust to intervene in the main physical limitations of cancer patients. Really important to know and how to structure a good prehabilitation plan. At the moment, we know the relevance of pre-rehabilitation for just to improve outcomes in oncology. So this is a key aspect. Again, advice on lifestyle pillars, and I can tell you a small story about one of our trained physiotherapists just recently called me just to check. She was taking our course and had a patient who was on omega-3, and she was undergoing through knee surgery. And she knew from our classes that omega-3 could decrease or increase the chance of bleeding during surgery, and she was quick to identify that and also to stop the supplement beforehand. So this is one example of how these informal contacts really make a difference. And then just confidence to refer once more to other professionals. GPs, they also have a unique role because, again, it's a relationship developed across sometimes in the span of years. They have in-depth knowledge of previous clinical history, so not only about cancer, but what happened to that person before, and their knowledge of the family and knowledge of the social context, which is so important when we're trying to implement behavior change. And opportunities and advantage of knowing more in this area just provide advice in all lifestyle pillars at all stages of the cancer journey, and including survival, and especially survival because they will be following many of these patients. And then just the opportunity of knowing more about implementation of behavior change, because we can know everything about lifestyle change and lifestyle pillars, but still be quite challenging to implement change. And that's why we have a coaching module on our course. It's exactly because of that, because we really need to sometimes motivate people for change and empower people to make changes as well. So all of these is quite relevant. And then for clinical oncologists, many opportunities again, and especially for clinical oncologists, I would say, there's a relationship of trust with the person. And it's even more than that. The person is so vulnerable when they get diagnosed with cancer that they really put themselves in the hands of clinical oncologists. And there's really a trusting relationship that can develop. And then in-depth knowledge of their clinical history. They are present in all stages of the disease and including survivorship here as well. They have a central role in multidisciplinary meetings, and they can really coordinate the roles of different health professionals to improve lifestyle for that person. So advantages of getting deeper knowledge, a better symptomatic control using lifestyle interventions. And again, neuropathy is such an intervention where we can intervene beforehand in prevention just before starting chemotherapy, for example. And knowing these strategies is usually very, very useful. Then getting updated on integrative oncology and lifestyle guidelines. They're always changing, and implementation again of behavior change techniques, and referral to other lifestyle professionals when it's needed and appropriate. Nutritionists are really sometimes the first point of contact with lifestyle. So nutrition is often really a priority for people with cancer. And it's really, really an opportunity to provide personalized plan to a particular person. So getting deeper knowledge in lifestyle oncology, it really allows us to check and know what to do with particular nutrition plans, and knowing what to do at different stages of the disease and different treatments. Then nutritional and lifestyle intervention to reduce side effects. And for example, ginger is such an interesting intervention for nausea prevention, or at least to nausea reduction. So that's one of the strategies we use. and then implementation of behavior changes, and knowing when to refer. Again, it's important for any professional. And finally, psychologists, they have a very close relationship with the person. They have longer duration of consultations. And again, they have access to patients in the community. So knowing more about cancer and the impact of cancer treatments in their physical health, but also in their mental health, health can help quite a bit. And then advice on other lifestyle medicine pillars. And this is particularly key for psychologists because if you're treating someone with depression, for example, you really need to know the impact of changing their diet, reducing um, fast absorption carbohydrates, for example, in their diet, or even implementing an exercise routine to improve their mood. So it's really impossible to practice good mental health without knowing the other pillars, and again knowing when to refer. And this is common to all professionals. And again, that's why we decided to include to actually provide a course to all health professionals, and not only one class of health professionals, because it's really from this network, from this collaboration, that something special is born, and that we can all make a difference in people's lives. So that's it. That was my presentation for today. So I'll stop sharing. And yes, and I would love to introduce you to our guest today, which is Nurse Matthew Fowler. Hi, Matt.
Hi, how you doing?
Welcome, welcome. It's a pleasure to be with you. And so, very briefly, I'll introduce Matt. Matthew Fowler is a nurse consultant specialized in oncology and hematology with a career spanning over 2 decades. He has a Master's of Science in Nursing and a postgraduate certificate in advanced clinical practice. He's currently doing PhD, and I think you're in your last year, which is amazing, focusing on advanced practice in cancer nursing, vascular access care, and the management of low-risk febrile neutropenia. Matt practices at the University Hospitals of Derby and Burton from the NHS Foundation Trust, and is also a lecturer at multiple levels, undergraduate and postgraduate. So I just want to welcome you, Matt. Thank you for joining us today.
Thanks, Dr. Ferreira. It's nice to be here.
Um, so I would love to start by asking you why oncology and hematology? What was so special about that, and what sort of steer you towards these areas?
That's a really good question. It's one I was asked earlier, actually, and I hadn't thought
Right.
about it for a while. But my grandma, had acute myeloid leukemia when I was a teenager, and she was quite young. So I got exposed to visiting her in hospital, and I was watching what the nurses were doing, and I liked the way that they interacted with the patients. So I was about 16, and I thought, oh, that looks interesting. And the rest is history. I've started my training nearly 30 years ago now, and I've worked in oncology and hematology. I'm a bit of a hybrid nurse. I've done both for about 25 years now, and still really, really feel very privileged to do the job that I do.
Thank you.
Hi, Matt.
Hi,
Nice to
Anabela,
see you. I'm
and you
so
too.
glad you to be with us today. So I thought asking this, and could you please share how advanced clinical practice is shaping cancer care, particularly in your areas? Um, what can you say about it?
Yeah, so we've had an explosion of advanced practice roles for nurses and allied health professionals such as physios, radiotherapy radiographers, nutritionists, brought on, unfortunately, by the lack of medical cover initially. So we had to think of different ways of working in the UK, so that they opened up advanced practice a little bit similar to how they did in the US and Canada. So we've been fortunate enough to be able to access these roles. We have prescribing rights. We examine patients, can request investigations, but still very much from a nursing angle, and we work alongside our physician colleagues. So I do 3 clinics a week, 2 in colorectal oncology, 1 medical, 1 clinical, and 1 in hematology, but I'm always working alongside consultant physician and attending. So yeah, we've been very, very fortunate. We can do lots of procedures, but I don't tend to do those anymore. I tend to focus more on the clinic side of things and working in the emergency setting for our cancer patients.
Very good. And how do you see lifestyle interventions fitting into the scope of advanced practice?
Wow,
Is it possible?
it was really interesting listening to Dr. Ferreira, because I started thinking about a patient that I saw on Tuesday in clinic who's having long course chemoradiation for a rectal cancer, and she's actually a nurse. And she'd said to me when I saw her in clinic to get her ready for her next cycle of capecitabine, just to see how she's getting on with the radiotherapy. She was like, Matt, I think I did something bad last night. I went out running, and the nurses told me I shouldn't do this. And I was like, well, who told you shouldn't go running? She went, the chemo nurses, they said I can't go running. And she's a member of a running club, and it's really, really important to her. So I was able to dispel that myth immediately. I think the other thing that she'd been told, and invariably it is nurses that do tend to do this, she'd been told she can't work while she's undergoing treatment. She's a nurse lecturer. She does a lot of her work from home. She occasionally does have to go into university, but I couldn't see any reason why she couldn't work. And that's really important to her. So I think we often say things that are quite outdated when we actually need to start thinking more about the evidence base for lifestyle interventions for supporting cancer patients undergoing treatment, whether that be in the curative or the palliative setting. We really do need to reframe the way that we talk to our patients, the way that we educate them. And I don't think we do enough to talk about the evidence base surrounding, good nutrition, access to exercise facilities whilst undergoing treatment, and how this improves patient outcomes. So I think programs like this are excellent for raising awareness, but it just really piqued my interest thinking back to the interaction I had with this patient on Tuesday.
I'm glad, Matt. I was going to ask, because you have such a scope of experience as well, and you have been practicing for more than 20 years, right? And
Yes.
I was wondering if you notice a difference between, what patients ask, comparing the start of your career and now, and if they're more interested in these approaches that are more concerned with lifestyle and that we're not as trained to provide, basically.
That's a really good question. So if I think back to when I first worked on a bone marrow transplant unit in the 1990s, we actually had exercise bikes on our bone marrow transplant unit for the patients, and we'd encourage them to use them. And this was in the 1990s, but then they got removed. It was infection control or something or other. It normally is. And then we've never really looked at it again. And I find that when I first went into oncology nursing, the patients were very passive with regards to the physician says, the nurse says, the patient does. Those days are gone. And I'm glad they're gone, because patients are much more inquisitive now. But I think physicians are a lot braver with what they'll say to patients sometimes, whereas nurses are very, very cautious. And we often worry that we might get into trouble for giving advice out. So we tend to be quite guarded. And I think that needs to change. It really does need to change. And I think we need to stop being so paternalistic and maternalistic with regards to the care that we deliver to our patients as nurses. I think the physicians I work with, they tend to be quite on point with regards to, yes, I'm happy for you to do that. Yes, I'm happy for you to do that. No, probably best you don't go skiing when I've just started you on a blood thinning medication. But the nurses tend to be too cautious in my experience. And I think we need to increase the education of nurses and have better access to our AHP colleagues, such as nutritionists, physiotherapists, psychologists, so that we truly do deliver holistic care. I think when it comes to exercise as well, I've worked at some hospitals that have partnerships with the local gymnasiums, and the PTs, they actually have specialist training in how to look after cancer patients. So that cancer patients can get free access to visiting a gymnasium whilst they're on treatment. I could think of patients with prostate cancer, for example. They often get weight gain with the hormones. So these guys, they used to get real benefit from going to the gym. And I think those kind of programs we need to really explore, not just in the hospital, but equally the services that we can access outside of hospitals to deliver evidence-based care.
Yeah, so this is not restricted. That's a really key point, not being restricted to the hospital environment. And I think everything was so focused on the hospital environment for the past decades. And now I guess we have no option but to expand at some stage, right? Because
Yeah,
it's really it's really the patient. Yes, we provide medications and we provide interventions, but it's really what they do on a daily basis that really counts as well. So it's an interesting perspective, absolutely.
I have an experience in Edinburgh with the program Move More, and I could see when we visit over there the community, how they do those exercise programs, and it's amazing. But as you say, normally the doctor must say you must practice exercise. So it still, you have that program, but still doctor may say that the professionals in healthcare must advise that to patients, so they go and do. So about emergency oncology, Matt,
yeah.
what do you like to share about that in your cancer nursing experience?
So one of the reasons I was attracted to my current organization, it's 120-kilometer round trip for me to go to work. So, and I live in Birmingham, so there's plenty of cancer centres I could work with in Birmingham. But the hospital in Derby at the cancer centre, we've got our own emergency room. So all of our patients with cancer and non-malignant haematology can access emergency care in a dedicated facility outside of the emergency room. And it's predominantly led by advanced nurse practitioners. We do have 2 doctors on the unit as well, so it's a real nice multidisciplinary team.
Mm-hmm.
And we have a team of nurses that care for the patients as well. We're open 7 days a week. So it's not a case of a Monday to Friday, 9 to 5 service. We're there till 9 at night, and we're open at weekends as well. So that patients with cancer on treatment with a complication of their disease or their treatment get access to healthcare professionals that are specially trained to care for them. We've got a wealth of point of care facilities, so we can get COVID, flu, biochemistry, hematology. All of these results are available within about 5 minutes of the patient arriving. So being able to deliver that really intensive care in a local setting in a cancer centre, and equally trying to keep people out of hospital. And it kind of feeds into my doctoral work around low risk febrile neutropenia. I'm looking at the Spanish CISNI tool. I'm trying to bring that into clinical practice so that we can try and get some of our low risk febrile neutropenic patients at home, as opposed to our traditional model, which is to admit and 4 days IV PIP-TAZ. But yeah, just being able to keep cancer patients away from the emergency room, because it's not the right environment for them. I will caveat it with, the emergency room is still the right place for some of our patients. If they're having a big bleed or suspected cardiac event, then we're not the right place. They need the access to the emergency team. So, but yeah, that's what attracted me to go and work there, is that ability to deliver a lot of same-day emergency care and keep people out of hospital.
And Matt, a curiosity, are there lifestyle or self-care recommendations that you can help to reduce the risk of emergencies like febrile neutropenia? Is there any?
I think it boils down to education. I think it's so important. And I think we need to empower the nursing workforce to be a little bit braver. The default a lot of the time is you have to come in. This could be neutropenia, without thinking, well, they're 1 day post-treatment, that they're highly likely to be neutropenic. Let's keep them at home, give them some good safety netting advice. And I just think we need to be a little bit braver. And I think we need to be able to be reactive with regards to access to community services such as nutritionists, physiotherapists, all the models of care we have in the hospital. I think we should have in secondary care. And I think it's doable as well, because we've got pockets of these services out there. I just don't think we're very good at tapping into them. And like Dr. Ferreira said, the GP brings everything together. We need to liaise better with our colleagues in primary care, so that they have better oversight of what's happening with patients. But definitely more access to community services to try and keep people at home.
Thank you, Matt. And I was just thinking, because sometimes you're there with someone providing intensive care, and it's quite a challenging time for them as well, because probably very uncertain as well. How do you keep someone, or how do you help someone keep calm and grounded, and just help with someone's well-being while you're doing this intensive intervention? Because I think it might be quite challenging.
This is uncanny. I got asked this question earlier by somebody as well.
All right.
The thing that I always do is, no matter what situation is in front of me, my facial expression is the same, my non-verbal communication cues are the same, and my voice remains the same. I always remain calm, because for me, when I appear calm, everybody else around me should be calm. And I equally want the patient to be calm and have trust in me as the nurse that's looking after them, knowing that they're receiving safe care, that we're doing everything we need to do to keep them safe, and that they get their interventions in a timely manner. But remaining calm is, even inside, that patient is there and their blood pressure's dropping, their oxygen levels are dropping. I always say, do the simple things. Give them oxygen, give fluids, give antibiotics, get the bloods off, keep repeating the observations, get the intensive care team down early. Don't wait until they've become really, really sick. Let one of the registrars know that they need to come down soon. But these aren't very difficult things to do, but always calm and never, ever panic. Even inside, if I'm thinking, I really don't like this situation at all, always calm. And then I find everyone around me stays calm.
Yeah, absolutely. They really look to you to see what's happening and how they should react. Absolutely. And what do you think are the main challenges of people in those situations coming in from assessment? I'm sure people can get a bit nervous with that, but are there any particular challenges, or I don't know if you have a clinical case to share with us in terms of what happens to people basically in those circumstances?
So I can think of quite a young lady that I looked after recently. She was in her early 50s and had just been diagnosed with a metastatic cholangiocarcinoma and was due to start FOLFIRINOX chemotherapy later on that week. And I'd seen her. She came in as an emergency to us on a Sunday. And I can still see it now. I remember her daughter wheeling her onto the unit, and I just took one look at her and I thought, this lady's dying.
Mm.
I can't coat it any other way, but as experienced clinicians, I know when someone's dying, and this lady was actively dying in front of me. So the daughter saying, well, you need to sort her out because she's starting chemotherapy next week. I knew that her mum wouldn't be starting chemotherapy next week, and the daughter was heavily pregnant as well. So it was all confounded by this. But I just took the daughter to one side, got the nurses to sort her out a cup of tea. Then I could work with the patient. And the first thing I did was ask her, what do you think's happening? And she said, I think I'm dying. Am I? I said, yeah, I'm pretty confident that you are. And it's difficult I've just met this person. She doesn't know me. So you don't have that time to build up a therapeutic relationship. It's not like a patient that I've seen in clinic. This is the first time I've met her, but she actually said thank you. uh, and it was very, I always say this, it's a privilege to be with people at any stage of their cancer journey. But when it comes to dying, we only get one opportunity to get it right. And often what I tend to find now, particularly in oncology, is we're not very good at letting people die sometimes. We've always got another magic pill, a something or other inhibitor, or the latest drug has just been approved, when actually sometimes they're not right for the patient. And we're very fortunate where I work. We have an inpatient palliative care ward. They're pretty much unheard of in the UK. Patients tend to have to go to hospice or they die on a medical ward or on the oncology ward. But so I phoned up a responsible oncologist. She wasn't even on call, but I knew that this was going to be quite a big decision. I phoned up. I said, I'm really sorry, doctor, but this is the situation I've got in front of me. She went, Matt, you have carte blanche. Do what you need to do. I suspected this might happen. So I was able to fill out, we have respect forms in the UK as opposed to do not resuscitate. So the patient could tell me what her wishes were. And she didn't want lots of intervention, but she wanted to be comfortable. So I was able to start some pain relief for her, give her some fluids. And I suspected she'd got an infection as well. So I did treat her with intravenous antibiotics in the palliative care ward. And then I had to refer her to the palliative care physician. And she actually got admitted direct from our emergency oncology admissions unit to the palliative care ward. And she did die 4 days later. She never got to meet her grandchild. But I got to spend some time with the daughter as well afterwards and just spend time with her. So whilst it sounds very bleak, I go back to what I always say. I feel very, very fortunate to do the job that I do and to be with people at what is invariably one of the most awful times in their life. But I think we all as healthcare professionals have a duty to give people a good death. And as I say, we only get that one opportunity to get it right. And I often find in oncology now, the patients on the inpatient wards, they've got metastatic cancer, they've got lots of other comorbidities, and the oncologists are trying to manage all of these comorbidities alongside the cancer and the complications of treatment. And it's really difficult. But
Yeah.
I still don't think we're that good at saying, no, I do think you're dying now. This might be your time. What do you want? What do you want to do? And if they say, I really want every treatment going, I want you to do everything you possibly can, doctor, then, I think we need to work with the patient and try and come to a compromise as to what works for them as a balance. But sometimes, no, I think we need to be a bit braver at recognizing that someone's dying.
Yeah, absolutely. And some people just want that confirmation and reassurance, and they're so tired as well of doing all these interventions. Yeah, absolutely. Have a very similar experience.
This story is incredible, Matt. Thank you for sharing, really.
No
I was
problem.
not expecting palliative care story in an emergency room, really. Uh, but I can imagine this is possible, and your experience in oncology care, of course, you managed this the right way. Thank you. So, and about the fact that you also train undergraduate and postgraduate nurses, how do you incorporate lifestyle medicine principles into your teaching? Do you do
So,
that?
yeah, interestingly, the one place I am able to do this quite easily is when I teach. I teach in Bethlehem.
Mm.
So we've got a master's program in cancer nursing and palliative care nursing at the University of Bethlehem for the post-registration registered nurses that are working in cancer care. We can integrate it there quite easily because they're very, very open to
Mm,
discussing, particularly because I'm not sure if it's something to do with the Middle Eastern culture, but they're very into nutrition and into looking after themselves, apart from the smoking, I will say that. But they're really open to talking about nutrition and because food is really, really important in their culture, and they're quite resourceful as well
mm,
in Palestine. So that I do find it very easy to incorporate teaching about nutrition, exercise. Uh, Trying to encourage them not to smoke is a bit of a difficult one. Uh, but yeah, they're very, very open to it. Whereas in the UK, the focus is very much on the tumor biology and the treatments and how do I interpret this investigation. It's very medically, but there's a medical model that's quite physical based. Whereas in the Middle East, they're very open to looking at exploring uh, the lifestyle aspects of care, I find.
mhm.
Yeah, amazing.
Very good.
And I actually have a question about exercise and culture, and you have the perspective of both cultures. And because we find in Portugal, for example, and I was living in Australia before, and it's a cultural very much connected with physical exercise, and people are really used to have a good sense of proprioception, and people just, do some form of physical exercise across their lifespan, and sometimes, and in Portugal is not quite like that. So physical exercise is not really something implemented, and the sense of your body is actually super different as well. And sometimes we're recommending some sort of physical activity or physical exercise to people that are in their 60s or 70s and never really experimented with something like that. And I was wondering if you find these cultural differences and how you deal with those.
So what I tend to find is it's not so much cultural differences where I work, it's more socioeconomic, logistical differences. So we look after quite a rural community in Derbyshire. We've got an area called the Peak District, so there's lots of hills, lots of beautiful outdoor spaces. A lot of people have dogs. And I think, exercise isn't just about going to the gymnasium, is it? It's about getting outside in the fresh air. And I find my patients that live more rurally are way more in tune with their bodies, in tune with nature, in tune with their surroundings, the environment, and are very keen to get out, explore, and live. Because I think it's so, so important to live with cancer and not exist with it. Whereas my patients that live more urban in the city, they're not so keen. They'll turn up for
Mm.
their treatment when they have to. They're not very good at calling in when they're unwell, which is why when they do present unwell, they've normally been unwell for a few days. So they end up being told off by me. Uh, Whereas my patients that live more rurally in with less social deprivation, they tend to be way more open to exercise and all the other things that we've talked about. So I think there's work to be done there. And I think that's why I think we really need to look at our community services and think about, community centres, looking at support groups locally so that they're more bespoke to the population around the area, because one size doesn't fit all, does it? So I think that's where we need to go with this.
Yeah, brilliant. Mm.
Matt, Diana shared in the beginning of her presentation that we healthcare professionals must lead by example. So, can I ask you about you? What lifestyle strategies have you adopted?
I'm getting closer to 50 now. I'll be 50 next year. And what I've noticed is in the last 2 years, I think it started during COVID. I had a bit of a self-awareness check and I'd started to put on a few kilos. So I bought a Peloton bike. That is the best thing I ever did. So I've done 30 minutes on it today and I play tennis once a week. So on a Tuesday night, I play outdoor tennis. I mean, in the UK at the moment, it's between 0 and 3 degrees. There was some ice on the court, but we still played. And I think it's about, and I take my dog for a walk every day. And that's what I mean about exercise. It doesn't have to be about lifting weights and going to the gym or expensive sports. I take my dog for a walk around the village that I live in, and that's, a 1.5 kilometer walk that I do every day. And it's beautiful, and I'm getting outside, I'm getting some fresh air. But tennis is really important to me, as is my Peloton bike as well. And I think the key is to find something that you enjoy doing that works for you.
And do you see your team works do the same? Can you see any change in health professionals to leading with some stress or some questions? I'm thinking about burnout.
Yeah, that's a really good
an
question.
issue nowadays.
Yeah. So my team have access to a clinical psychologist once a month, and they get a team clinical supervision. I'm fortunate enough to receive some money from NHS England so that I can provide regular structured supervision for my trainees in a safe space. We do it online once a month. So we do that. But the one thing I have noticed, particularly with my age group of healthcare professionals, particularly the nurses, we're getting way more aware of our bodies, and we're doing more exercise. I think there's a move towards practicing more mindfulness techniques. Yoga is another really powerful tool that isn't used nowhere near enough. I equally think complementary therapies need bringing into this as well, because again, there's this whole, I hear the nurses, or it's always the nurses, and I am a nurse and I want to defend my crew, but it is always the nurses that go on about, you can't do this, you can't do this, you can't do this. We need to turn that on its head. You can do this, you can do this, you can do this, you can do this. If you get a temperature, please call us up. We spend so much time focusing on what they can't do and what patients shouldn't do. They end up being quite scared about what they can and can't do. So invariably, they end up doing nothing. I think the model needs turning on its head. I really do.
Yeah, absolutely. And I was curious, you were talking about exercise in terms of or movement for health professionals, but I was wondering if you, because you touch on palliative care as well, and you encounter so many challenging cases, is there any form of support or like team support that your team has to sort of deal with grief and, just all these things that come with being with someone who has cancer?
Yes, so we're very fortunate. Our clinical psychologist offers once a month group support for our trainees, and that's for the nurses and the doctors it's a drop in. You don't have to book, you just turn up. It's not a one-to-one, but everybody knows that there's ground rules. So when they go in, there's ground rules. Whatever is said in the room stays in the room. It's a very safe space, because I think that you have to feel safe in these spaces, because you can become quite vulnerable. I felt a little bit vulnerable discussing that patient that I'd looked after, but that's part of working in healthcare. But yeah, we do have this so that particularly if we have a difficult case, we can debrief. We equally work in quite a tight team of doctors and nurses. It is predominantly doctors and nurses in my team. That we all get on really well with each other. We make time for each other outside of work as well. So, for example, I work with an oncologist from Hungary. I'm actually going out to see her this weekend, just for the weekend. She's invited me over. And I think it's things like that. And we probably won't talk about work that much. I want to meet her dog and I want her to tell me what life is like back in Hungary for her before she comes back to the UK. And I think it's really important we do those little things to check in with each other and to talk about other things as well. I want to know about the dog. I want to know how the kids are doing, or what your husband or your partner's up to, what you did at the weekend. We don't do enough of that sometimes, just about checking in with each other about what is going on in our normal every day-to-day life.
Yeah, absolutely. And there was a question coming to my mind as well, because I'm really curious, because you seem such a passionate person in your profession as well. And I was wondering how you see, because we're often told as clinicians, and especially during our formative years, that you shouldn't get too close or too involved with our patients. And I would really love to get your perspective on that, and what's your thinking process on that?
That's a really good question. I used to work as a clinical nurse specialist in lung cancer in the early 2000s, before we had a lot of the fancy treatments that we've got now. So my patient's life expectancy was very, very short. And I never forget going to a patient's funeral, and I didn't like it. I felt that I shouldn't be there, but the family had invited me. And I don't know if there's a right or wrong way, but for me, it's not my grief when I see a patient that's dying, and I don't know if that's a protective mechanism that I've developed over the years. But it's not my grief. And equally, when it comes to the family as well, it's their time with their loved one. It's not our time. We just need to be there to facilitate whatever we possibly can to maximize the time that they have with them. But I think it's really important to have. We have a lot of humor at work, and I think that's really, really important. And equally, we spend time with each other outside of work. And again, for all of our mental health, because it is challenging working in the field. That's one of the reasons that attracts me to emergency care. You don't necessarily build up that, particularly if I think about working in bone marrow transplant, we'd get to know those patients and families inside out, back to front. Working in emergency care, your transaction with the patient and their loved one is very transient on that day. Then they go off to the ward or they go home. You might not see them again for another few months. So you don't get to build up that relationship. Where I do notice it is in clinic. I really, really notice it when I do my clinics, particularly the oncology clinics. You get to really know those patients. And when I think about my metastatic colorectal patients that are coming to the end of their third, fourth line treatment, and you've looked after them for a few years, that is hard, particularly on that last consultation when what we tend to do is we say, we're not discharging you, your follow-up's open. So yes, we haven't got any more chemotherapy drugs for you, but your follow-up's open. If you feel like you want to come back to the clinic, just give the secretary a call and we'll see you. So it's not that finite cold, the transaction is complete. You can't, these are human beings we're dealing with. We're not in a supermarket. So I think it's really important. I think the other thing, I could talk about this forever, but the other thing, we need to get better at promoting palliative care as treatment, because it is. It's not,
Yes.
oh, there's nothing else we can do. You're off to palliative care. Right, this is the next line of treatment for you. We're going to refer you to the palliative care team. Now, that is real holistic practice where you've got your physician, your nurses, all of your AHPs, your chaplains. We forget about the chaplains as well, about spiritual and pastoral support that we provide for care. And that feeds into what you're talking about as well. We need to get better at providing good spiritual care for our patients. And we often equate it with religion, and it so isn't. We need to separate that. Everyone's got their own spirituality, and they might want to access different means of looking into their spiritual needs. And that may come from a chaplain, it may come from an imam, it may come from a priest, it doesn't matter. But yeah, I do think that's another area that we need to look at as well.
Yeah, absolutely. Thank you so much, Matt. I don't know if you want to ask anything else, Anabela. I don't want to cut everyone's word because I would be chatting for the rest of the night.
I want to thank one more time, Matt. It was a privilege for us to have you here
It is for
in
me.
our last day, but thank you so much. You are an inspiration for me, and it was very good to have you in this online chat. Thank you, thank you.
Not at all,
Yes.
not at all.
Yes, absolutely. Thank you so much, Matt. It was such a pleasure to meet you.
Thanks, Dr.
And
Ferreira.
or just Diana, please. And
Okay.
yeah, it was lovely to have you, and it's such an interesting conversation, such interesting insights, and I really thank you for that.
Likewise.
And yeah, and for everyone watching, thank you so much for being with us for 4 days. This was the last one, and I think it left us with our heart full. So everyone, thank you. Don't forget, we have a certificate course in lifestyle oncology starting in February 2025, open to all health professionals. I said 3-month duration yesterday, but it's actually 6-month duration. So if you want to enroll, just get in touch with us. And I hope you have the best evening, and we say goodbye for now.
Bye-bye.
Goodbye.
Bye. Thank you. Thank you, Deborah.